Good afternoon, and welcome to the Bipartisan Policy Center's event on improving the Medicaid buy-in for working individuals with disabilities. I'm Catherine Hayes, BPC's Policy Director. Today we'll be discussing the Medicaid buy-in, how it works, and how it can be improved for working individuals with disabilities. In December, BPC will be issuing a report that includes regulatory and legislative recommendations to further improve the Medicaid buy-in. I would like to thank the Robert Wood Johnson Foundation for their support of our efforts here, and would like to introduce Kathy Hempstead, Senior Policy Advisor at the Robert Wood Johnson Foundation, for a few words.
Thank you, Catherine. Hello, everybody. We're really proud to be able to support this work, which is very consistent with our mission of increasing everybody's access to affordable health care. And, today's topic bears on the relationship between healthcare and work, which I think a lot of people are thinking about lately. I think, many of us get our healthcare at work, and in the context of the recession today, I think people are worried about the fragility of that link and thinking about how many people might lose healthcare as they may lose their jobs. And it also reminded me a little bit of some of the conversations that we've been having about work requirements in Medicaid, which sort of proceeded from the idea that maybe you could incentivize work by restricting people's access to healthcare. And I think that one of the things that we learned from that was that people need to be healthy in order to work, and actually taking away people's healthcare creates a barrier to work. So I think that's a nice lead into thinking about today, which is another policy that deals with the relationship between healthcare and work, but I think is directionally correct, because really operates from the assumption that to incentivize and support the work of adults with disabilities, we need to make sure that they maintain access to the healthcare services that they need. And I think it's a specific situation where we really can see this sort of paradoxical outcome. As adults with disabilities earn too much to lose their eligibility for Medicaid, they then actually lose access to the services that they need that allow them to be independent in their community and actually work. So we have, I think, a really good fix for that with this buy-in program where people can buy into Medicaid. It's also an interesting example of a blend of public and private insurance markets, because many times these buy-ins kind of sit on top of employer-sponsored insurance. So I think today we're going to really talk about this policy, sort of where it's been, its history, how it's working, and importantly, some ways that we can make it better and allow it to better serve a larger population of individuals. So with that, I want to say thank you, and I'm really looking forward to the day, and I will kick it back to Catherine to introduce our speakers.
Thank you very much, Kathy. Moderating today's discussion is Henry Claypool, who is the Policy Director for the Community Living Policy Center, and he is also a consultant for the Bipartisan Policy Center. Henry is also the former administrator for the Administration on Community Living. Henry?
Thanks, Catherine. First, I wanted to thank BPC for doing work like this, picking up particularly healthcare and Medicaid issues important to people with disabilities. It's really important work, and it's great to see the BPC highlighting it. I wanted to just share that this kind of has a significant intersection with my personal issues. I worked at the Centers for Medicare and Medicaid Services at the end of the Clinton administration when the Ticket to Work and Work Incentives Improvement Act was passed, and there was a Medicaid buy-in associated with that legislation. So I worked on the passage of the legislation and the implementation of that buy-in. And then on an additional personal note, I actually was a Medicaid beneficiary and relied on a Social Security work incentive called 1619B that allows one to maintain access to their Medicaid while working. It has a number of benefits and challenges, and I think the Medicaid buy-in is certainly an improvement. And so, highlighting this today, I think is going to be an important discussion, and I'm so glad you've been able to join us today. So before I introduce my first guest, I wanted to just remind those folks that have tuned in that if you have questions, we'd appreciate you asking them to the live chat function on YouTube, post them on Facebook, or the Twitter, the hashtag they're using is BPC Live. So feel free to raise questions and share them that way. But now moving to our first discussion, it's with a woman named Teresa Wynn. And Teresa received her Master's of Public Health from the University of Colorado. Her focus is on healthcare policy and systems improvement. She's experienced with policy development in both the state and federal government, and she's currently an instructor at the University of Colorado in the School of Medicine, developing trainings and curricula for state and community providers and partners in the intersection of healthcare transition and employment for people with disabilities. So welcome, Teresa. And I just had a question maybe that would get us going, and please feel free to go beyond this question, but can you tell us about your experience finding a job after you finished school and how you learned about the work incentives like the Medicaid buy-in?
Well, thank you, Henry, for that introduction. And yeah, I can certainly talk about that. I was fortunate enough when I was in school for my master's to be tapped into a variety of internships and kind of job shadowing experiences for my education. So I was tapped into a few networks that helped me find kind of the first job right out of my graduate career. While I was in school, I worked in a clinic to help, in a healthcare clinic to help families and youth with disabilities understand the change in policies and programs that would affect them as they transitioned into adulthood. And within that clinic, I, had the opportunity of kind of practicing my policy communication skills and really focusing that behavioral change factor on families and youth with disabilities. This led me to that first job that really started it all, which was the same position, but in the State Department for Medicaid. So I was at Colorado's Department of Healthcare Policy and Financing as the liaison for a federal program called Money Follows the Person. And again, my role was to really communicate that policy to the stakeholders, the folks that we were trying to implement the policy for, to help them understand what services and programs were available to them. So that, starting working right after graduate school was a really great experience for me. And I had access to private health insurance through my employer. And in my personal experience, this was already kind of a game changer for me as it expanded access to a lot of specialty providers in the adult healthcare system that was not available to me previously when I was 100% on Medicaid as a child. And so that was already a game changer. However, I did experience a medical crisis during that first kind of work position that, made me rethink a little bit about kind of the wraparound gaps that were missing in my private insurer coverage. So that's kind of what exposed me to the Medicaid buy-in program. And I truly learned it through my community of disability advocates and friends in Colorado by just kind of comparing experiences and trying to balance that work, working in my career, but also making sure that I was healthy enough to work. So I would say, personal experience was what exposed me to Medicaid buy-in.
Great, thank you. I'm just thinking more about your response to that, the fact that the buy-in gave you some security on top of the employer-sponsored coverage. You mentioned the fact that you learned about it through the disability community, I think. Were they active in the state in shaping the Medicaid buy-in? Do you know much about how it transpired in Colorado?
Yeah, I know a little bit. The individual that comes to my mind had probably the most influence in changing kind of the resource and asset limits and income limits that were a part of the Colorado program. And so it really evolved because of the community, the disability community being active in advocacy and really working with those policymakers within Colorado's Medicaid program to make those changes and to make our program kind of one of the model programs in my mind to aspire to for a buy-in.
Great. Another question based on your response was, you mentioned kind of the provider network, and I wonder if you could share with us a little bit more about that distinction. You know, the fact that you had a more robust provider network, I think, through employer-sponsored coverage. And it's interesting that Medicaid would be a safeguard or a fallback too. And I wondered if you had anything to say about kind of the relationship between the Medicaid and the provider network that you use through your employer-sponsored coverage.
Sure. I can talk about that. I want to take a step back and talk about, my disability a little bit more in depth and give you an understanding of how that affects me day to day, and then go into how the wraparound coverage has really helped me maintain my health. So I was born with a brittle bone disorder called osteogenesis imperfecta, or OI for short, because that is such a mouthful. This causes my bones to be very brittle. I use a power wheelchair for mobility, and am very lucky to be quite independent when my health issues are managed well. And as a child, when I broke my bones, which was quite frequently, because you're growing as a kid and your bones grow larger and there's less support for them, so they fracture. I was pretty used to that life of breaking my bones frequently and having the assistance through my family because I was a kid and that was natural to help me during recovery and help me get back on track with school and whatnot. As an adult, although bone fractures are less frequent, a bone fracture can really get in the way of life for an adult with a disability of mine, especially when, I talked about being quite independent. So, having a career and living independently, a bone fracture can set you back about 1 to 3 months, depending on the severity and the care that's involved. And so in 2017, that was probably my first kind of adult experience with this disability. And I was in an accident that caused me to break both of my legs, so both femurs, and quite a big deal. And I needed surgery, and that really set me back about 6 months from life. And again, this was in the middle of, having a job and living independently and managing, kind of my other aspects of my life. And at the time, I, had only employer coverage for health insurance, and it really it was bittersweet because the employer coverage helped me find a pretty renowned specialist in the state that can help me with this very complicated fracture of mine that had a very big possibility of not being able to heal. It's just the nature of this disability and whatnot. But he was well known in the community, although he only took private healthcare insurance. And so, again, that was an extreme win, I guess, in my case, that I was employed and had that access to him to help me recover. On the other end, during recovery, I needed a lot of daily support. So, because I lived on my own, I didn't really have, a plan or a fast plan to have caregivers and personal care assistants be in the picture for me day to day. And this crisis really, really opened my eyes to the possibility of needing the personal care assistant services really at any time in my adulthood. And so this was really when I explored Medicaid buy-in and had began to have access to that service that's often not provided within private healthcare insurance, which is the personal care assistance that's needed when folks live with a disability or, disability like mine. And so, what that care really looked like was giving me the help and the assistance in my activities of daily living, in my personal care, my hygiene care, and really helping me be able to maintain that position of mine at state Medicaid that I really loved and enjoyed doing. So that's kind of how these two systems interact. The private health insurance that really tackles the technical aspects of health, right? Do you need a doctor? Do you need surgery? Of course, there is going to be some coverage that is beneficial in there. But within the additional health aspects, I think that come with a disability that most folks don't think about, such as activities of daily living. That's not really thought about in the private world as wholly and as universally as within the Medicaid system. And so this buy-in really kind of helped me manage my entire aspect of healthcare as a person living with a disability. I hope that answered your question, Henry. That was very long-winded.
Oh, thank you, Teresa. It very much did, and I think really helped our those that have tuned in to understand kind of the complexities of living with a disability and the important role that health insurance and medical assistance play. It's a complicated net that we have to weave to maintain ourselves in the community often, and your personal story really helps folks understand that. Moving on to kind of a more of a technical aspect of the buy-in program in Colorado, states often have income and asset limits. I think Colorado may be a little different. I'm going to ask specifically about assets. And are they treated differently there? And I ask because I really hope that you can help us better understand what people have real lives and they want to plan for buying a home or for retirement or these types of things. And I was just curious about, your personal thinking and buy-in participation, and are those limits, how do they affect you?
Sure. Like I said, I'm so thankful for the work and advocacy that the disability community has done around this. In Colorado, resources and assets are not counted toward eligibility for the Medicaid buy-in program here in the state. And so, my savings for a future home or my retirement savings does not count towards the 450% below federal poverty limit of income that is required to be eligible for Colorado's buy-in program. So really, the only limitations that, of course, I have to pay attention to is in Colorado, what that means is you can make up to $9,453 a month and still be eligible for this program. Understanding this and knowing that, it's a little bit more flexible within my program that I belong to, I'm able to build more of a stable picture of what my future can look like as an adult with a disability. I can plan for these things such as a future home or, other expenses that I would like to to take care of and cover in my adult life, and just knowing that my health will be managed and maintained, and that I have a plan for when situations arise that are unexpected, really helps me in that future planning for myself. I think many times people with disabilities are often constrained in future planning because of assets and resource limitations. And so for me, that's not the case in my personal experience. And I'm very thankful for that. I'm very thankful for the buy-in program that has been built in Colorado.
Oh, thanks again, Teresa, for sharing that. I think your remarks really highlight for us that the Medicaid buy-in is a state program, really hinging on the state's specific Medicaid program. And so it kind of sets up well our next presenter. We have Annette Shea joining us. And I wanted to give the group an introduction of Annette and then move on to some questions for her after she gives a presentation. But before I do that, I'd like to remind folks that they have an opportunity to submit questions. And they can do so by, again, using the live chat function in YouTube, posting them to Facebook, or even Twitter, the hashtag again, BPC Live. So with that, I'd like to introduce Annette Shea.
Thank you, Henry.
My mic is coming through. I'm giving an introduction of Annette, and with an emphasis on Medicaid and systems which support employment for workers with disabilities for more than 25 years. Annette worked at the Department of Health and Human Services. She worked in the Administration for Community Living, and she also did a stint at the Centers for Medicare and Medicaid Services. She also worked with Massachusetts Medicaid. Annette is a Medicaid buy-in for workers with disabilities subject matter expert. So she's in a perfect position to give us more information about this important program. And with that, Annette, I'd like to turn it over to you and take it away. Thank you.
Thank you, Henry. And thank you for the opportunity to present on the Medicaid buy-in for workers with disabilities, reinforcing its relevance and importance in our healthcare system. Medicaid buy-in is an optional eligibility group which has tremendous value for workers who need services only offered by Medicaid, such as home and community-based services, vital to successful community living. It's important to note that Medicaid buy-in is often used to supplement other payer sources, and I've noted that there. Work is more than a paycheck, as we know. It gives individuals a sense of purpose and belonging in their communities, and research has found that Medicaid buy-in is good for beneficiaries as well as employers seeking to hire, train, and retain qualified staff. And the business case has been made that is good policy for state Medicaid agencies' bottom line. As beneficiaries' income goes up, Medicaid costs go down. TWIA is really accelerated Medicaid buy-in participation among states. It was and is a real difference maker. Key to mobilizing that participation was the investment in state infrastructures dedicated to promoting the buy-in and employment for people with disabilities. TWIA wasn't the first Medicaid pathway for workers with disabilities, and it's still not the only one utilized by states. But TWIA really elevated the role of Medicaid for workers with disabilities. And then there's what myself and others, and many, consider the buy-in's best friend. And that is Section 1902R2 of the Social Security Act, often referred to as the R2 disregard. This is how states really encourage earnings and employment. In the sequence of events, what happened after TWIA, another good outcome, was that CMS realized that their interpretation of 1902 R2 was too restricted. How can you truly encourage employment and restrict earnings? So CMS fixed the problem. Their words directly from their state Medicaid director's letter in 2001. You'll see I pulled a quote from that state Medicaid director's letter, which demonstrates CMS's intent with revising the rules for R2. Being more flexible with the treatment of income also alleviates some of the administrative burden for states' eligibility processes. Then with R2's help, here are some key features of Medicaid buy-ins which promote earnings and employment. That's the no income limit or higher income limit, no asset test, and down the line. As Teresa referred to, in Colorado, there is no asset limits. And the financial eligibility, what it includes, whether it includes spousal income. The inclusion of premiums is not required. The use of a grace period for people who have cyclical conditions and may have an interruption in employment, and the inclusion of workers 16 to 18 and 65 and older. And slide 8 shows the current landscape, which has 45 states with Medicaid buy-in for workers with disabilities. And features where there's 8 states with no limit on earned income and 22 states who don't count spousal income. So it's these states are able to do this using the R2 disregard combined with a Medicaid authority. And you have states considering making changes that are more friendly to earnings and employment, and DC and Hawaii are 2 states that are contemplating adding the buy-in to their Medicaid portfolio. Now I wanted to touch on the difference makers and recommendations as part of this panel discussion today. Slide 9 and 10 here highlight the key difference makers for successful employment in the Medicaid buy-in as a critical part of that. No one should have to choose between healthcare and work, but unfortunately it's happening. Ideally, all states would provide a pathway to achieving their employment potential for workers with disabilities. Leadership is key, and I note congressional champions, but state legislative champions are also just as important. Understanding the vision of Medicaid buy-in and information on how to utilize it strategically is so important. Sometimes the technical elements become overwhelming, especially during times of competing demands. State decision makers want to make changes to promote employment, but are often confused by the different nuances in authorities. Finalizing the 1902 R2 rule really made a significant difference. Rules and regulations for the buy-in would create a much needed opportunity for community input, filling the information gap and addressing the many myths and misinformation that exists there still today. And lastly, I can't say enough about the role of resources. The MIG helped in funding to create IT opportunities for states, training, education, outreach, data collection, and elevated the role of Medicaid for workers with disabilities in ways which would never have happened without it. Some of the resource elements and processes were sustainable and were sustained, but much more is needed. Resource helps states make decisions and raises expectations for earners. And finally, streamlining the process to add, implement, or change Medicaid for workers with disabilities would ease the administrative burden for states. And thank you very much. My last slide has your Medicaid buy-in for workers with disabilities Q&A released last year. State Medicaid direct letters related to the buy-in, links to those. You've got the R2 disregard, the rules on that state Medicaid director's letter. These are quite old, but they're still relevant. And then just a release when the Medicaid infrastructure grants concluded. There were about 36 states, I believe, still engaged and hadn't closed out their grants, and so they were asked to submit their top 3 outcomes from their perspective for a report, and those things are listed in this report, and I hope you find them helpful. And that's it. Thank you very much. Hand it back over to Henry.
Oh, thank you, Annette. That was really a great presentation. I would just note for the audience, because I know there are some policy wonks out there, that the 1902 R2 reference is in a state Medicaid director letter. It actually came as the 4th letter of a series of letters CMS wrote following the Olmstead decision. And, you know, with the passing of Justice Ginsburg, I often remember how critical her role was in drafting that carefully crafted Olmstead decision. And it allowed really CMS to issue technical assistance on a program like the Medicaid buy-in. So, you know, the evolution of the law is a really powerful tool. And I think Annette is really helping us understand, you know, how well states can use the flexibility. And so I have some questions for Annette that will lead us into your questions. But first, I just wanted to get your thoughts on, Annette, on how CMS can support states to understand the nuances of the program design that you've raised here for us today.
Sure, thank you. States and those providing technical assistance to them would benefit tremendously from formal guidance, either in the form of regulation or sub-regulatory information on what's possible through Medicaid buy-in authorities. It would need to be accompanied by gathering questions and input from the community. So as done for other Medicaid authorities, states and other interested parties have been asking this for several years. And as I mentioned, simplifying and streamlining the processes would make a significant difference, but they would need to be gathering those questions and information from the field in order to be responsive. That's my opinion.
Thanks. Another question for you. From your experience working in the federal government on these kind of eligibility groups, like, you know, the different buy-in authorities, how might CMS issue and the provision of technical assistance? Could you give us a sense for what CMS can actually do in that regard?
Well, the thing that comes to mind, I guess, and even from my experience working inside CMS, was the significant amount of technical assistance to states on projects and initiatives that they offer all the time. And a dedicated resource for the buy-in for workers with disabilities would be received very well, I think, from the states seeking to add the group or those wanting to make changes, policy changes to improve it. There is still so much misinformation out there and so many questions that they search for sources of answers when CMS is really the best source, or certainly a technical assistance center that they already have a relationship with or that they could engage with to make it a more centralized and obtainable process would be most helpful.
Great. And Annette, you also touched on the Medicaid infrastructure grants. And I think it's important to mention those were part of the Ticket to Work and Work Incentives Improvements Act. They were rather substantial. It was, I believe, $500 million over 10 years. So it was a lot of money in those days, and certainly even in today's dollars. a significant investment. Could you talk about the role they played and leading to the kind of the buy-ins that we started to see emerge after the passage of TWIA?
Right. Thank you. I think what some may consider, I want to give an example of a smaller deliverable of the MIG grants was technical assistance to states to help them create an identifier for the group so that states could collect data on the group more easily, including tracking which Medicaid group the buy-in enrollees may have been prior to Medicaid buy-in enrollment. This also helped conduct analysis for policy changes or forecast the future for enrollment. MIG also provided resources for training and outreach for frontline workers to help individuals make informed decisions about work, helping to integrate Medicaid buy-in into a centralized Medicaid eligibility system to create a smooth experience for beneficiaries and alleviate the administrative burden for states is also very significant. States creating boutique programs for Medicaid buy-in or separate access for workers with disabilities faced administrative challenges, especially when broader healthcare reforms were put in place. So a lot of these tools were supported through Medicaid infrastructure grant resources.
Thank you. Now I've got a couple of other questions, but I also wanted to open up. We've got Teresa with us if she has any, but one program that I wanted to mention was that Social Security created a group of benefits planners and counselors, and they made grants to, I think, community-based organizations to play a role in helping people understand the work incentives that were available and specifically, the role that the Medicaid buy-in might play. And Annette, I'm wondering if you had much exposure to those programs and the work that was done by those community-based organizations.
I did. So the Medicaid infrastructure grant allowed states to use up to 10% of their resources, and they would typically use it for that type of service, those type of direct care service, and helping individuals make informed decisions and also helping them understand even the relationship between the Medicaid buy-in and maybe transitioning from Social Security benefits. And when I worked inside Medicaid in Massachusetts, I also worked with benefits planning and those the work incentive grants. And they really created a lot of enthusiasm when it came to promoting employment. One of the things they did too, that may not be, so people might not be aware of, is that they did a lot of group training. So they did a lot of one-on-one, but then they went out in the field and really tried to create a broader sense of at least generalist when it came to helping people understand the importance and the opportunities available to them when it came to employment.
Great. Teresa, bringing you into the conversation, I'm curious, your experience working with the advocacy community, are there questions that you might have about the program that maybe Annette can help us shine a light on before we turn to our guests for any questions they might have?
I don't have any questions at this moment. I just, obviously hope that this is adopted in all states and so that folks can have increased access to options when they decide to go to work and stay in work. But thanks, Annette, very much for your expertise.
Thank you.
Yes, we really are lucky to have Annette with us. For those of you in the audience that have followed the buy-in for a while, Annette is not an unfamiliar face or name associated with this work. And with that, I wanted to turn to some of the questions that are coming in from the audience. We've got one that pretty straightforward with 45, it's from Corinne, who posts on Facebook, I guess. 45 states have established Medicaid buy-in programs. However, many states don't take advantage of the significant flexibility available to them. Why is that? And, I can speculate, but let's let Annette speculate and see if she has some thoughts.
Oftentimes, it's a really good question. I will say that there are more and more states taking advantage of it, and now that they have some experience with the buy-in, and they have data available to them to test out and make the business case for why it's so important that the buy-in is part of their portfolio. It's good for Medicaid, it's good for employers, it's good for the individuals. Those aren't in ranking order. So when it's a win-win and they have the data to support that, they can convince their financial gurus to make the decision to make these changes. If they don't have access to the data they need, then they're less likely to make policy decisions because they just don't have the resources or the tools. But you'll see more and more states, like Washington State was the most recent state that removed all income limits. They have no asset limit. And so I think that they are using the tools. They're just one example, a recent example of using the tools available to them.
Just an additional consideration in response to Corinne. Oftentimes, the program is managed by somebody that works in the Medicaid operation, and where they are in relationship to other personnel in Medicaid, I think, has some ability or inability to influence the trajectory of the program, like the changes that might be pursued, who's thinking about the unique design challenges that they face, how it fits in with the rest of the Medicaid program. So there really is a role for people to engage directly with their state Medicaid program on this, asking questions about the Medicaid buy-in program, why it's structured the way it is, urging them to reach out and seek additional information. And that's provided us with some rich resources today. Those may be new to some of the personnel that are managing this program. They may not have been following the evolution of the program that closely. So, I think there are other ways to raise awareness in the state beyond just relying on CMS. And sometimes that state level advocacy work really helps draw additional attention to it.
And can I quickly add, Washington had a legislative champion. They had a state legislative, they had legislation that passed that helped move it. So that's it.
Great. I'm looking at another question here from Jamie on YouTube asks, buy-in rules are so different from state to state. What is the best way to keep up with changing legislation in regards to the buy-in in each state? Do you have any thoughts on tracking this across the country?
Is this question for me?
Sure, please.
So I would say that using that Washington example, they engaged with their, they had a legislative champion, they had advocacy in state. There are other states out there that also have advocacy, and they're going to their state legislators or they're forming work groups, and they stay in touch with the community. But it's usually significant when a state proposes any legislative changes that will have an impact on Medicaid. Whenever they do that, there's any Medicaid changes, they're supposed to have a comment period. It would be a state plan amendment. So that's something that they would need to post, and sometimes you'd be surprised they don't change as often as you think they do. So I would encourage connection with any work group or advocacy group that's in that state.
Thanks, Annette. I've got another question that is technical in nature, and I'd like to ask it to you. Is there talk of changing, this is Jamie from YouTube, is asking, is there talk of changing how unearned income like SSDI or spousal income is counted for buy-in eligibility purposes?
Well, the opportunity exists today. So it could be talk. I don't know what state Jamie's asking from, but this doesn't need to be talk. It exists today. I believe so. The opportunity does, because states do it using an R2 disregard.
Yeah, and I think that's what we're hearing from Annette today, is that there really is quite a bit of flexibility in program design here. And that engagement with your state about how it's structuring a buy-in program is oftentimes the best course of action. Trying to engage the staff in understanding how well the program's working, who's being served. These are the types of questions that I think can lead to a re-examination of how the program is structured, and might give an opportunity for you then to provide some additional information to the state personnel about how to structure the program. It really is a rich work incentive, and hopefully state Medicaid personnel are seeing it that way. Given the kind of set of questions we have, I've got another one, Annette, for you that's around the R2 rule, it looks like. Please clarify again, this is Amina from YouTube asking, please clarify again how R2 final rule can be used to make the buy-in program more flexible. So I think
So
they're asking for just the clarification around how wide the authority of R2 goes, but that's my interpretation of the question.
Okay. So, and this is another example, and the last question is also one that highlights for me the need for regulation and opening up for questions. You should be asking that of a regulation and a rule for the buy-in. It just is allowed, the treatment of income, there's flexibility, and it includes disregarding earned income. It includes disregarding unearned income, right? Because that's what Colorado does. So it's written in the final rule, but I would say there's friendlier language in that state Medicaid director's letter that I have linked to the end of the presentation. And it's just how a state submits the proposal, the request to CMS, and asking for what they would like disregarded when it comes to income or resources, assets.
Thanks, Annette. I've got another question from Caroline that I think opens it up for us a bit. And Caroline asks on YouTube, do you think we will see legislation on this issue soon? Is this a priority for Congress? So before I ask Annette for an opinion, her presentation has really showed us the broad flexibility that states have right now. There's great discretion in how they structure the Medicaid buy-in. So I know there has been discussion of a need to get legislative fix specifically for the population that's over age 65. But what we've learned from Annette's presentation today is that if a state chooses to pick up the Balanced Budget Act authority and then uses 1902 R2 to disregard income, they're not bound by those age limits that show up in the TWIA program. So they wouldn't have to terminate someone's eligibility at age 65. So that's just one example of why legislation isn't necessary. Not saying that legislation wouldn't be clarifying or certainly help in some way, but the legislative process is a significant undertaking. Rulemaking, as Annette has mentioned today, is something that is an administrative task that CMS can take on. While it may be time consuming and require the personnel at CMS to sit down and really put pen to paper, go through a comment period and finalize these rules, it's really quite maybe a better mechanism to address some of these technical issues. And so that's another opportunity. One thing I would say about legislation is we've mentioned the role that the Medicaid infrastructure grants played. And they were really significant in spurring states to act, getting stakeholders energized around the reality that people with disabilities can work, earn income, hold on to assets, and remain holding on to the life-sustaining Medicaid services that they might rely on. Just for example, personal assistance is a very unique service that isn't available through commercial insurance. And so it's one of the key services that people hold on to so that they can, again, work and get their basic needs met. The point I'm making is about legislation, and the Medicaid infrastructure grants would require something like that. So there may be a role for the Congress to play in authorizing additional spending around this to, again, spur states to act. I don't know, Annette, if you have thoughts on this question of, do you see legislation on this coming anytime soon, or if this is a priority for Congress?
One way I would think it would be helpful is if they didn't have more than one pathway, if it was a combined pathway, if TWIA didn't just go to 65, because states now are layering on, they're using both means of pathways, and certainly, you've got a couple of states now saying, well, now we know our folks are coming close to 60, workers with disabilities coming close to 65. They want to keep working. Why should they have to stop? So now we have to go back and add this group, when if there was TWIA just included the 65 and older, it would certainly make it easier for states. And of course, any resources helping states to really boost this program. And really, it would underline the fact that this is here to stay, right? If you solidified and codified this group in regulation, came out with something that really made a statement that said, we know we owed you, we said we were coming out with something, now we're doing this, and this is our way to say this is here to stay. Medicaid for workers with disabilities is here to stay as a pathway. Right now, that's what's needed. Until something else better comes along, this is it.
So I've got another question, Annette. I know that you follow the buy-in fairly closely, but this one's really going to push that. So given the pandemic, one of our guests asks, do you know what effect, if any, the pandemic has had on buy-in participation?
I know that there have been some rules with regards to how the buy-in is treated in state Medicaid programs, trying to protect the group. even if they have an interruption in employment. There is some thought that there could be even more of a sense of urgency to make sure that the buy-in is available to be flexible for workers with disabilities who maybe need to work from home for a period of time, people who may have lost their jobs and they're trying to seek other employment. And the pandemic has highlighted the disparities among populations. So just a sense of urgency not to let workers with disabilities as a group become marginalized by this to the degree they can be protected, to make sure they stay a priority.
Thank you, Annette, for that. And thank you, Teresa, for sharing your story with us. I think today has helped us begin to better understand the Medicaid buy-in, the role it plays in people's lives, and how states can really access current information to affect program design and hopefully make the program better suited for others to participate. But again, thanks so much to Teresa and Annette for joining us today. We're drawing close to the end of our time, and so I wanted to hand it over to Catherine and allow her to take us home. Thanks, Catherine.
Thank you so much, Henry, and Teresa and Annette for your participation in today's program. Also, thanks again to Kathy and the Robert Wood Johnson Foundation. As I mentioned at the start of today's event, the Bipartisan Policy Center is working on a report that will outline really and explain the Medicaid buy-in program and the federal authority and the options that are available to states. It will discuss the policy levers that are available to states and federal agencies, and finally make recommendations for federal policymakers to improve consumer access to Medicaid buy-in programs. These recommendations will be based on today's event, as well as discussions BPC has had with stakeholders, including consumers, state and federal agencies, and other experts. We hope that you will tune in December for the release of that report. Thank you very much for joining us today, and please subscribe to BPC's YouTube channel for information on future events. Take care.